Hello everyone, and welcome to the third part of this four-part series on advanced MRI techniques. My name is Rihan Dasuki. I'm an assistant professor of radiology at the Faculty of Medicine Zagazig University, and today we will be discussing MR perfusion. So, what is perfusion? Perfusion refers to the passage of blood from the arterial to the venous circulation passing by the microcirculation. So, from the beginning of the first pass arterial entry into the tissue, passing by the capillary bed and entering into the tissue extracellular space until the venous system. Perfusion-weighted imaging refers to a group of MRI techniques that are able to exploit or give insights into the perfusion of tissues by blood. There are three common techniques widely used to derive one or more perfusion parameters, and these are dynamic susceptibility contrast MR perfusion, dynamic contrast enhanced MR perfusion, and arterial spin labeling. So let's start with dynamic susceptibility contrast. Dynamic susceptibility contrast is the most commonly used technique, and it is used for imaging of the brain perfusion. In this technique, we used susceptibility-weighted signal loss when a rapid injection of gadolinium bolus enters into the capillary microcirculation, and with this we use a T2 or T2 star weighted image acquisition to acquire this rapid loss of signal. And when this signal decreases during the first pass of the gadolinium bolus, we can note a marked reduction in signal intensity, and after this reduction in signal intensity, we can produce maps denoting the time to peak, mean transit time, cerebral blood flow, and cerebral blood volume. So what happens is the signal decreases over time, giving T2 star or T2 star weighting. It will decrease over time due to the T2 shortening effects of the gadolinium, and then this signal will slowly recover, and using this change in signal, we can calculate our perfusion parameters. So let's get into some detail regarding the perfusion values. First of all, we have time to peak, which is the time at which contrast concentration reaches its maximum. So basically, from the time we inject our gadolinium bolus until the maximum contrast peak, this is called our time to peak. Second of all, we have mean transit time, which corresponds to the average time measured in seconds that a red blood cell spends within a certain volume of the capillary circulation. So, assuming that our peak or our reduction of signal intensity has an area under it, which is the area or the tissue of interest that we have imaged, the mean transit time is the time RBCs take within the tissue of interest, measured in seconds. Okay, so let's go to our third parameter, which is the cerebral blood volume. This is defined as the total volume in a given amount of brain tissue, about 100 grams of brain tissue, commonly in milliliters of blood. So basically, the whole area under the curve is our cerebral blood volume. Finally, we have our cerebral blood flow, and this is defined as the volume of blood passing into the capillary microcirculation per unit of time. So basically, it is the volume, the cerebral blood volume, but in terms of time. So basically, we have all of this area under the curve, but in order to calculate cerebral blood volume, we also need to divide it by the time that this blood has taken within this area of tissue. Let's go to our second perfusion technique, which is the dynamic contrast enhanced MRI. And in this technique, the dynamic contrast enhanced MRI can be used in many other body parts, such as the liver, the prostate, the breast, and the heart. Here, we manipulate the gadolinium-induced T1 shortening when a bolus of contrast is also injected in a rapid fashion, as we did with the dynamic susceptibility contrast enhancement, and we perform a T1 image acquisition instead of T2 with the dynamic susceptibility. In this case, we acquire our contrast injection in the pre-contrast phase through the first pass of the bolus as we did with susceptibility, and we also add several delay times. In areas where gadolinium accumulate, there will be a signal enhancement. According to this pattern of enhancement, we will have different patterns of contrast uptake and washout, and by this way we can plot contrast or enhancement curves, and this will denote different pathologies according to the behavior of the contrast going into and going out of the tissues. So, a parameter specific to dynamic contrast enhanced technique is K-trans, and K-trans is a measure of the capillary permeability, which we can obtain using dynamic contrast enhanced technique. It is calculated by measuring the accumulation of gadolinium-based contrast agent within the extracellular extravascular space. So let's see what are the types of curves we can note, and the most important of them are the breast MRI enhancement or the Kull curves, and what types of enhancement can we see in various different types of tissues or pathological changing types of tissues. Type 1 curve is a progressive or persistent enhancement curve in which there is an initial slow or medium-sized upstroke representing the first pass, followed by a persistent increasing enhancement. And this continuous increase in signal intensity is mostly indicative of a benign behavior or benign behaving lesion. Only in 9% of cases this can be a fallacy and can denote malignancy. Okay, so type 2 curve is a plateau pattern curve in which there is also a slow or medium-sized initial upstroke followed by a persistent constant enhancement, neither increasing or decreasing. So following this plateau, this will give us an indeterminate finding, so we will have to do some further investigation or biopsy to make sure, because this is somewhat suspicious of malignancy. The type 3 curve, which is the washout pattern curve, and this shows a rapid initial uptake and a rapid washout in the delay phase. And this is highly suggestive of malignant pattern of contrast enhancement. So according to the type of curve, this can reflect the type of microcirculation going on within this certain region of interest. Okay, so another clinical application of MRI perfusion is in stroke. But in order to understand this clinical application, we will have to talk a little bit about what happens in stroke. So what happens in stroke is that a blood vessel supplying a certain amount of tissue is occluded. The amount of tissue which is furthest away from the vessel or the vascular supply is necrosed first. So complete necrosis of cells occurs from the center all the way up to the periphery. The central part shows complete necrosis or death of tissues, and these tissues cannot be saved. However, there is an area of hypocirculation of tissue at risk, but this tissue has been compromised but is not completely necrotic. So we call it a penumbra, or an area of tissue at risk that still can be saved. And the area closest to this blood supply is normally perfused or viable brain tissue, and this area has still not been affected. So what this means is that over time, after this occlusion of the vessel, we have a large area of tissue at risk, which is represented in red, followed by central necrosis. This central necrosis increases over time with a decrease in the area of tissue under risk, and with progression of time, without any kind of treatment, all of this tissue will turn into a completely necrotic area or a large infarct core. So what we would like to do with MR perfusion is to early detect the area of tissue at risk, so we can give anticoagulant and save this tissue at risk and turn it into normally perfused or viable brain tissue, reversing the effect of the infarction. So let's see how we can apply this. First of all, we have the concept of diffusion-perfusion mismatch. What does this mean? This means that since perfusion-weighted imaging is more sensitive than DWI for detecting early onset of arterial occlusion, any area of restricted diffusion or reduced ADC is indicative of a total or near total perfusion deficit, and this tissue cannot be reversed or its effects have already happened regarding ischemia. However, the surrounding area of decrease in perfusion only shows a mild ADC change, if any, and the presence of the perfusion delay, whether in the form of elevated mean transit time or elevated time to peak, this will represent an area of tissue at risk with or without changes in ADC. So this area is the area of tissue at risk which we can provide with anticoagulant in order to reperfuse. The area of perfusion-diffusion mismatch is also indicative of clinical outcome. So if we have a small area of ADC and a large penumbra, this might be associated with a poor clinical outcome if this patient is not rapidly managed. However, if we have a large ADC with small penumbra, this might mean that this patient will have a much better outcome. But this all depends on how rapidly we manage our patient. So let's see this with some images. Here we have our diffusion restriction in yellow, which represents our necrotic infarct core. Second of all, we have our perfusion map, which represents the area of ischemic tissue, whether it is completely necrotic or only hyperperfused or penumbra, area under risk, which is represented in red. And here we can easily demonstrate the area of mismatch by separating or subtracting the red area from the yellow area, which is represented here as a blue area. So here we have a large tissue penumbra. This means that we need to rapidly manage this patient with anticoagulants in order to reverse the ischemic effects of the large tissue penumbra. Okay, so our last point that we will be discussing today is arterial spin labeling. And arterial spin labeling is characteristically a non-contrast technique, and it is also suitable when we cannot give our patients gadolinium due to certain limitation regarding the patient, whether it is chronic renal disease or the patient has hypersensitivity or reaction to this gadolinium contrast agent. So what we do to get our contrast is, instead of injecting gadolinium, we put a 180-degree radiofrequency labeling pulse outside the volume of interest, which is here. So here is our volume of interest, which is the capillary bed, and here is the area where we tag or label our red blood vessels. So the incoming blood is labeled or tagged with a 180-degree labeling pulse outside the volume of interest, and this blood will travel into the area or the slice of interest and will be imaged. So, imaged are acquired when the labeled blood has moved to the slice of interest. Okay, so imaging is repeated again, but without the labeling pulse. So we have a baseline which we can subtract the labeled image from the unlabeled image, and this difference between the control image and the labeled image will be proportional to the amount of blood flow that happened within the slice of interest. This theoretically is a very good way of performing perfusion. However, in real life, ASL suffers from low signal to noise, which means that the acquisition times can tend to be very long, and achieving an acceptable imaging quality is somewhat difficult. At the end of this lecture, I would like to thank you all for your attention, and until next time, thank you.